Yeah, so I'm a neurosurgeon at Barrow, and I've met many of you before. So I'm going to talk about interventions for tremor, and there's a long history of using surgery to treat tremor. Like Dr. Evidente said, we do Parkinson's tremor, essential tremor, dystonic tremor, and the narrative of how DBS has really taken off with Parkinson's disease is very rich with a lot of good data. And I'm going to kind of focus more on tremor during this presentation. It's interesting to see all those wearable devices and the lengths people will go not to have to see a neurosurgeon, right? I mean, you see those big weights they're wearing and everything, and I think that's one of the, it's kind of why I'm here, is there's a degree of demystifying what the surgery is about, but also validating patients' own experiences of what they want for themselves. You know, people with essential tremor particularly often have had this condition for decades, and it's interfered with their life for decades. But they also make a choice that they can live with it to a certain degree, and they're not seeking, for example, intervention beyond just taking propranolol or primidone. And that's the patient's right. You know, nobody can tell you like you have to have this treated. And the space we're in is one of doing interventions to the brain for quality of life. And that requires a really good, the risks got to be low and the benefits have to be high to sign up for that. And that's where we are. I mean, that's what we have to offer. But nonetheless, there's always risks. And there's a large element when it comes to having a neurosurgeon address your condition of like, thanks, but no thanks, not for me. It doesn't matter how much it's going to benefit you. It's not something people are keen to do unless they get there themselves. And people like myself being here today, or Dr. Evidente, you know, as a lifelong clinician, you know, for your care, help guide those decisions and at least inform, because you want to be informed about what your options are when you decide what you do want and what you don't want for yourself. So I'm going to be reviewing the interventions. I think it's useful to think of like what are we doing to the brain when we do these interventions. And I make the analogy to heart rhythms, right? Because people kind of are familiar with arrhythmias, you know, when the heart's skipping a beat, whatnot. And, you know, there's different strategies one can use for heart arrhythmias. I guess we're not at the point yet where we have wearable technologies for heart arrhythmias like Dr. Evidente described for tremor, but think about this. So you've got the medications, right, that we all think, all right, I'll just take a pill, right? And it'll treat my condition. There's amiodarone. And then there's ablations. You can actually go with a cardiac electrophysiologist. They'll take you to the suite. Instead of implanting a device, they'll actually pass some wires. Let's see, is this a, yeah. They'll pass some wires in the heart through a vein. They'll pass it into the heart, and they'll actually go to the location, one of the nodes where the abnormal rhythms arising from, and they'll do an ablation. They'll ablate that area. They'll basically replace healthy scar or abnormal heart tissue with scar tissue, essentially. So they're creating an ablation, right? So getting an ablative procedure for a heart arrhythmia has been around for a long time. And if that doesn't work, or as an alternative, you can also get a pacemaker. And everybody knows what a pacemaker is, right? So the pacemaker is basically, you have these electrodes, they go in the heart, and they help correct these abnormal heart rhythms. So, you know, look at this slide, right? And like, you know, blink, and here we are. Abnormal brain rhythms, right? So this is kind of the space I'm working in. So on here, you've got medications. There's propranolol. The only on-label medication for essential tremor is propranolol. You can do an ablation. And the history of ablations extends like 70 years, believe it or not. Like 70 years ago, they were doing ablations of the brain to treat essential tremor, Parkinson's tremor. And it went from having to crack the skull open and go in there and, you know, take blood vessels to drilling small holes in the brain and passing a probe and testing the area and then kind of cauterizing brain tissue to where we are today, which I'm going to describe. This is focused ultrasound. And so there's a journey in surgical interventions that started with more invasive approaches toward making this lesion. This is an MRI of the brain. There's a patient I just treated last month. And right here, that white area right there, that is the ablation. And I'll show some other pictures of what ablations look like. But an ablation, again, we can kind of, you know, make it sound nicer. Like, oh, we're just putting some scar tissue. we're destroying brain tissue when you do an ablation. And there's a history of doing these destructive procedures, ablative procedures, to help these arrhythmias that applies to cardiac conditions as well as brain conditions. And then there's the pacemaker for the brain, right? That's the deep brain stimulation, and we'll talk about that as well. So the goal here is to restore function, right? I mean, it's a much different equation than what we have with like brain tumors or, you know, a pinched nerve that's causing weakness in the leg. This is stuff that people choose to live with. People choose not to have an operation for, and they will have the support of the neurologist, their primary care doctor, their family, not to opt for surgery. But it's FDA approved. The government said, okay, we've proven that this improves quality of life. So the real key here is saying, you know, 6 months down the road, is your life better? You know, would you do it again? And that's kind of how we kind of give the sense, intuitively at least, whether what we're doing is the right thing for patients. So DBS has been around since the 1980s. It's always important, I think, to realize we're not doing anything experimental. Many of you already know what DBS is. Those who don't, it's maybe new to you, but it's nothing new. So it's been around since the 80s. It was FDA approved in 1997 for essential tremor. So that's 25 years ago. The FDA said, oh, this is great. Let's go for it. It's not a treatment of last resort. That's another important thing. I do spine surgery, and with spine surgery, when we talk about rods and screws, I tell patients, get your injections, do your physical therapy, do everything you can until you're clawing at the door begging for surgery. Because in this case, we are kind of approaching this like a treatment of last resort, where once you go there, you can't go back. And you get scar tissue, you got the rods, you're kind of getting your anatomy changed. That's not the case with DBS. DBS is not one of those things that you got to wait and make sure you exhaust every other alternative, because the safety is sufficient to justify the operation and the benefits, the efficacy on quality of life. So it's not a treatment of last resort. There's a large experience. The number is always going up, but a couple of years ago, they hit the 200,000 mark worldwide, and it is covered by insurance. So people always ask that. So I'm going to talk a little about, what DBS is, what it can help with the surgical procedure, and then I'm going to wrap up talking about focused ultrasound. So I'll get a little bit more into what that's all about. So this image, historical perspective, this is the brain. You can see the eyeballs on the right with a nose on top. And from my angle, I can't see this too well, but there's a white circle right here, right in the middle of the brain, and that's a thalamotomy. That's an ablation. So that is basically, actually, that's the same picture. That same picture is what a brain tumor can look like. So the reaction of the tissue as it dies and the brain reacts to it creates what we see, this ring right here. So that's a thalamotomy. And the way neurosurgeons first discovered that this destruction of the brain can actually help was by accident. There are some very primitive operations being done for Parkinson's tremor in the first half of the 1900s. And around 1954, a surgeon went to do one of these primitive operations, accidentally cut a blood vessel, stopped the bleeding, but had to stop the operation. So he did not complete the operation because he knew he had likely caused a stroke. The patient woke up, and not only were they still able to move the arm and not have any evidence of a stroke, but their tremor had stopped. And that was kind of the eureka moment of, hey, wait a minute, maybe we could do a different procedure and stop these tremors. So this surgeon started doing this on a more routine basis to treat Parkinson's tremor. And it turned out that that same blood vessel has a different distribution of blood flow from patient to patient. So sometimes a patient would wake up paralyzed, and sometimes they would wake up, as you'd hope, being able to move, but without the tremor. So there's a more variable outcome, but they refined this and continue to refine it to the point that they could just drill a small hole in an awake patient, check the area, find the area where the tremor would stop, and then create the lesion, the ablation. The way they would check it was with electrical stimulation. So the early 1980s, they had to have an awake patient, and they'd want to make sure they check, double check, triple check, they had reached the right spot in the brain, not the spot that caused paralysis, but the spot that would cause stop tremor. And they'd use electrical stimulation to mimic the effect of the lesion before they cauterized the tissue and destroyed the tissue and stopped the tremor. And so that was those are the early days. That's a thalamotomy. And so it turns out that you get side effects when you treat both sides of the brain that you don't get when you treat only one side of the brain. So it's the mirror image seems to have an effect on cognition, on speech, on balance, such that the conventional wisdom in the 1980s was that you could only do this procedure, the thalamotomy, on one side of the brain. And a patient came back to the surgeon in Grenoble, France, and said, "I want the other side treated." He's like, "Well, we can't do that. It's not safe." And but he kind of thought about it a little bit more, and basically, in effect, jerry-rigged a cardiac pacemaker to make a pacemaker for the brain, so that they could treat that second side in a way that was not ablative, was reversible, because you turn off the stimulator, like Dr. Abinanti showed, those tremors come back. And so they could treat that tremor in a way that if the patient had intolerable side effects, they could turn it off. So they basically went from the testing with electrical stimulation to a chronic implanted electrical stimulator, similar to a pacemaker. So there's a deep brain stimulator on the right, cardiac pacemaker on the left. Similar devices. And the components are placing wires through small holes behind the forehead into the nodes that control the tremor, and then passing the electrodes under the skin to where the pacemaker goes in the chest. And these are the approved indications. 1997, essential tremor. 21 years ago, Parkinson's was approved. 2018, epilepsy was approved. We actually have unique approvals for dystonia as well as for OCD. So this can help with many aspects. I think we're going to focus on tremor today, and the proof is in the pudding there, right? If you're shaking, it bothers you, and you're the right patient, you can get this operation to stop the shaking. There's Meg. Meg used to work at Barrow. Now she's with Medtronic. And this is a video of showing the reversibility of this. That's an action tremor, right? Somebody's trying to make a motion. Meg's sitting back there. I saw her earlier at the station. So, again, patients can't bring food to their mouth. They can't dress. They can't write. There's the shaky movement doing the spiral. And you can see this gentleman, we only treated one side on him initially. He came back later for the other side to be treated. But that's the patient controller. The patient can actually control the device. They can turn it off at night, for example, if they want. And so immediately the tremor is affected. The writing improves. They can feed themselves. So again, pacemaker for the brain. But it's a commitment, right? You kind of form a lifelong relationship having somebody who's going to be managing this device. If a patient shows up to me from Vermont having a DBS system that's dead, and they show up in my ER, I'm like, oh no, we're not supposed to do these to the ER, blah, blah, blah. First thing I ask is who's managing this? Because they're like, all right, and then what are you going to do for the once we replace the device with a new device? And it's really, they're basically, with DBS, implicit in that is a relationship with a neurologist who's going to be managing the programming. Think about this as an electrical therapy versus medical therapy. But you need surgery to have the therapy implanted, but it's not the surgery that stops the tremor. It's what the neurologist does. The neurologist activates the system and starts titrating and dosing the electrical stimulation that's delivered by the pacemaker. So DBS consists of having wires put in the brain that are powered by an internal pulse generator similar to a pacemaker. And the appeal here is the safety profile. And as we kind of circle back around and talk about the newer options, including focused ultrasound, safety is key. The adjustability is one of the appeals of DBS. So again, it's a commitment. You have an implant that's going to be there for the rest of your life, and you're going to have a clinician who's going to be responsible for programming the device. The newer technologies allow for 15-year rechargeable devices. So in terms of this not being a surgical treatment, you don't want to see me every couple of years, right? So I think the shift toward rechargeable devices kind of separates the surgeon from the patient a little bit more, such that the neurologist is going to be responsible. Ma'am, go ahead. Great question. I'm always surprised when somebody shows up to my clinic ready to consent for surgery, not aware that all this is going to be underneath the skin. I'm like, oh, you signed up for this therapy with the misunderstanding that was going to be outside. Everything's underneath the skin. Yeah. So incisions behind the forehead, incision kind of above the ear, incision on the chest, and everything is underneath the skin. You can feel the device underneath. You can feel the pacemaker. You can feel kind of a bump behind the forehead, but everything is underneath the skin. Nothing's visible unless you look at the protrusion on the chest in some patients. So yeah, no, good question. Again, I'm surprised. Sometimes I'm like, oh, you made it this far, agreeing to DBS, thinking this might be external. This is all internalized. So this is just to kind of see where it is, but all this is underneath the skin. You can feel the wire going down your neck, right over the collarbone, for example. So again, princess in the pea. Some people don't want to have hardware that's palpable, but this is underneath the skin. So the adjustability of DBS has been an appeal. for the therapy. For example, if you have speech side effects for essential tremor, if you turn off the device, those side effects go away, right? You're not stuck with those. The reversibility, again, Dr. Evidente and I have shown videos highlighting that if you turn this device off 10 years later, decades later, the tremors are still there. And it's non-destructive, so we're not destroying brain tissue with this. So those three, again, for the right patient, all that, but adjustability, reversibility, non-destructive. We'll kind of circle back around to that when discussing the option of focused ultrasound, which is sort of the state of the art of ablations of this thalamotomy that's been around for 70 years. So the key to good DBS outcomes, my yellow on white didn't appear as well here, but good patient selection is key, right? Dr. Evidente showed the slide of what this works for, right? That also means that there's things that this doesn't work for. And good patient selection is key. And for that, it's really important to have a movement disorder specialist who can screen and vet to assure that you're the right patient, right? I mean, I think that there's a world where people are more aggressive, and if this was super, like, if there's zero risk, what's the harm of doing this on somebody who's the wrong candidate? You find out later that, whoops, we put this in somebody who didn't actually have Parkinson's disease. That's not how we practice medicine. And that's why good screening, and I don't do the screening. I can appreciate essential tremor, I can appreciate Parkinson's, but I'm not as good at kind of discriminating somebody who may look like they have Parkinson's, but actually doesn't. Dr. Evidente is much better, and he's got the tools, including the DAT scan and the skin biopsies, that even in his diagnostic expertise can catch things that might have otherwise slipped through the cracks 2 decades ago before we had these adjuvant modalities for diagnosis. So good patient selection is in his hands, and then good programming. This is an electrical therapy, right? You need the surgeon to implant it, but it's electrical dosing that Dr. Evidente does that controls the symptoms. My job should be in red instead of yellow on these white slides, but good lead placement, doing it safely and accurately. So what I strive to perform is an operation that's done safely without complication, with the electrode placed in a location that when you see Dr. Evidente, to have him turn it on, there's no surprise in terms of benefits and side effects and whatnot. So the MRI is basically a roadmap. It shows us all the structures, and over the decades of DBS being effective, our understanding of those structures has improved. We're like, oh, look at that! You put an electrode there and you stop shaking. Oh, wait a minute! You put the electrode over here and you feel tingling, but you still shake. So we've learned a lot, and even in our current patients, we learn a lot when we place an electrode in terms of where the neighboring area of the tremor suppression can be tingling, can be clenching, can be these side effects. But these are all the networks that are kind of neighbors to each other that include the benefit as well as side effects. So when I do the operation, I'm basically making a small hole in the head, and I'm trying to hit a target within a couple of millimeters, a few inches deep. And there's different ways to check, double check, triple check at the time of surgery where I'm placing the electrode in an appropriate location so that we're not having to go back to surgery afterwards to make revisions. And that can be, first of all, having devices that allow me to be a sharpshooter. Second, there's recording brain cells, testing an awake patient for symptoms or side effects, or getting a CAT scan or MRI in surgery to visually see where the electrode is. These are all modalities to kind of help perform a safe and effective operation. Yes, ma'am? Yes, great question. There's been a lot of investment from all three companies that make these devices, Abbott, Medtronic, Boston Scientific, to demonstrate the safety of these devices in MRI. The MRI approval is what the FDA refers to as conditional. They say it's MRI conditional. That means that if you have a short circuit or open circuit, keep in mind you have about 16 different circuits in a complete DBS system. If one is faulty, you may still have optimal symptom control, but you may not be able to get an MRI. So yes, they've all been approved for MRI, but you'll always need the system to be checked before you get the MRI to make sure there are no short circuits or open circuits. There's a video on the right placing the stereotactic frame and doing awake surgery. When I first started doing this for my first several years, I was doing awake surgery. It's not that uncomfortable overall. but I think a lot of people look at awake brain surgery and say, you know what, I don't care how effective this will be for my tremor. I'd rather put a 5-pound weight on my wrist and do that instead, right? So not for everybody, right? I think that the awake experience, it's not uncomfortable, but I think it kept a lot of people from pursuing this therapy. So the stereotactic frame is placed, you get a CT or MRI, so you can see the anatomy, go to the OR, and then in some places, the standard is to pass through the brain like up to 5 different times, maybe sometimes more if necessary, and basically look at the lay of the land and seeing which one of those areas is right. Well, I think that there's been I really believe in this. I'm happy to hear my colleagues describing this too. A move towards single pass brain DBS surgery, meaning we're only having to go once, we nail it the first time, and we're done. That brain is valuable. I don't think that we can kind of make multiple passes to the brain with impunity. So the standard operation was before. It was actually the person who started, who invented DBS. His name is Benabid, and we call it the Ben's gun for Benabid. The Ben's gun was basically this targeting mechanism where you fire 5 wires in the brain at once, and you look at all the area and you pick the best one. That's called the Ben's gun, and I think the gun is an appropriate kind of a nickname for that device. But we've kind of moved away from that with asleep DBS. Yes. Great question. So for awake, for elderly, the side effects of anesthesia are those such that it might be better to do an awake operation. So I've actually, as I talk about asleep, the theory of asleep is more, you don't have to actually be asleep for it. It just means I'm not chasing tremor side effects or cellular recordings. I'm just getting a picture. We've studied that. I think that, maybe a day longer in recovery in some situations, but patients go home when you expect them to go home. So we can do it safely with the elderly. The anesthesiologist is a big source of variability. We don't have standardization. It's easy to put a patient to sleep, but say we just do sedation. One patient doesn't remember anything of the operation. Another one is traumatized when they see me afterwards saying, wait, I thought I was supposed to be sedated for the drilling. I remember everything. So that kind of experience is one where I think that the appeal of asleep DBS is the standardization of the patient experience. But no, they tolerate it, they do fine. And really, anesthesia has not been a reason to kind of, in our decision-making process of deciding who gets DBS and who shouldn't. So these are all toys that we can use. I actually use a surgical robot now as well. So we use robotics. These are all different ways to kind of hit that target within 2 millimeters through a dime-sized hole about 4 inches deep. So that stereotactic, that word basically means that's sharpshooting. We have all these tools we can use. These are the awake patient recording the cells. And this is a video. Dr. Evidente showed some of this, of what it looks like in an awake patient. It's really fun for the operating staff to see what this looks like, to see why we're doing this. But it's not necessary for the patient in my experience. And again, some patients are like, hey, I wanted to be a doctor when I was a kid. I like science. I want to be awake for surgery. And then the whole operation, they're complaining about their back hurting. So, again, it's not I haven't found awake to be really ideal for patients. So there's the awake. Asleep DBS basically takes advantage of improved understanding of brain anatomy over the 3 decades of DBS surgery. This is a cadaver. So now we know where in this MRI or this cadaver is a sweet spot to control dystonias, Parkinson's, things like that. And we combine that with improved MRI imaging. This is an MRI of the brain. These stripes right here are the same stripes we see on the cadaver. So we can see almost like cadaveric quality images in today's MRI that we didn't have when DBS started 30 years ago. They're kind of flying blind. Now we've got all these instruments. So we combine that with increased ubiquity of intraoperative imaging. So 20 years ago, we didn't have 3-dimensional CT scanners in the operating room. Now we're using this all the time for spine surgery. Spine surgery navigation is kind of standard of care in most places. And so we almost can borrow these surgical, now having a CT scanner in the operating room is standard for first world surgery centers and hospitals. So this means that as soon as I place the lead, I can do a quick image, see where I am, make sure I didn't throw an air ball and move on to the next side. So that combination of good imaging with rapidly available intraoperative imaging, preoperative imaging on MRI, intraoperative imaging with CT scan is what made this become an alternative to being awake and recording cells and doing all that stuff to verify that we've placed the lead in an appropriate location. Because not only do we want to make sure we're putting in the right spot, we want to make sure that if we put in the wrong spot, we can revise that at the time of surgery before the patient leaves the operating room. So again, I talk about the consistency. This asleep really kind of results in a more consistent operation. Same operation each time, less variability between case and case. Surgery has risks. I've done more of these in the last 10 years than anybody, and so being attentive, we can reduce risk, but we can't make them zero. So experience and attentiveness helps, but we're always looking for big bad brain bleeds that make you permanently and significantly worse after surgery than you were before. So far as the brain bleed, Plavix, aspirin, fish oil, often it seems like we see this in the usual suspects, somebody who stopped their blood thinner, but it would be nice to stop it earlier. The blood thinners there protect you. So oftentimes your cardiologist will say, oh, I only want you to be off this for 3 days. And then we have to kind of work around that. Infection, if you get an infection, the device has to come out. Lead reposition, even though I do my best to put in a location that we don't have to go back and revise it, about once a year, I'm having to reposition where a lead is in a patient. That's out of about 150 patients a year or more. Hardware failure, that's where you have a bad circuit that compromises your therapy, and you go back to surgery to replace the broken component. Patients can be confused. Parkinson's patients in their late 70s, I'm always kind of bracing for a little bit of confusion after surgery. Seizures, speech effects, any swelling can cause side effects, but that swelling, as that goes down, which it invariably does, those side effects go away. This is the incision. There's an eyebrow right there. That's a forehead. So behind the forehead is a half circle incision for the hole where I place the wire. This is on the chest, and this is a bald person. I think the scar's right there. So the scalp heals amazingly. Not everybody heals the same, but this bald person looks great, even though they have these half circle incisions right on their dome. So conclusions from this for DBS. It's a well-established therapy. It's been around for a long time. Earlier surgery may improve quality of life. So, in your agency as an individual, you choose to live a certain way and you have a choice to pursue treatments. But this may improve your quality of life if done earlier. And my experience has been asleep DBS renders this therapy more accessible just because that hurdle of having to sign up for the triple corkscrew roller coaster in awake brain surgery does not exist for this. In the last 5 years, we've seen new technologies ushered in with Medtronic, Abbott, and Boston Scientific on the market. Each one has kind of unique features that makes them stand out. Medtronic has this sensing capability that can actually facilitate the neurologist's management, not just of the DBS system, but of the medications. Abbott has remote programming options where you can actually have the device programmed from afar, and Dr. Evidente has taken advantage of that feature. Boston Scientific, just like I use your MRI to decide where I want to go and where the lead goes, their system kind of complements that approach using your postoperative imaging to inform programming in the neurologist office. So there's the sensing capability that Medtronic is pioneering, and it's changing every day. And I think when they get the rechargeable device this year, they're going to take that ability to sense the brain and determine how to treat the brain based upon sensing capability. I think that's going to be taken to another level in the next few years. There's the rechargeable devices that last 15 years. I understand Abbott's going to get theirs this year. And directional leads have been a game changer. Basically, what directional means is I place the lead, and then the technology can take it home in terms of location. So I place it within 2 millimeters. And then directional basically means that electrical field that used to basically just create, now you can actually shift it around so you can move it away from side effects toward the areas of maximum benefits. And all 3 devices have direction. It's a standard now. Yes? 15 years for a rechargeable, variable for a non-rechargeable.
How does it get charged? It's just automatically charged all the time?
No, you kind of have a little disc that sits in like a a recharging station at home. So you got something plugged in the wall at home with a little disc, and then you pick that disc up, you put it over, there's like something that goes over your shoulder. I know Boston has an example out there. I suspect Medtronic does too, where you can see what it looks like. You basically put it over your shoulder, there's a counterweight, and the little disc that recharges the system goes in, and basically you can position it. Once it's coupled with your device, it'll recharge through your skin, through your clothes. So if you're interested in that, they have them out in the stations in the hallway. But it's basically something like, maybe like a little bit larger, like a circle like this, something about this size that sits right there and recharges. Yeah. I think that's kind of if you think about this as a non-surgical treatment, but you need surgery for, I think the longer time you're without replacement, the more true that is. That's an electrical therapy. Let's see if this video starts. This kind of shows, let's see. Yeah, great. So this shows what directional can do. Think of yellow as side effects and that aqua blue as therapy, okay? So this is what directionality means, is instead of just kind of creating a big bubble, you can actually steer it toward that area of maximum benefit away from the area of side effects. Focused ultrasound. So this is our goal. There used to be like advertisements in Southwest Airlines for Gamma Knife, which is a radiation-based ablative treatment for brain tumors. And up in Seattle, they had a center that was doing Gamma Knife to do these thalamotomies. So Gamma Knife it's radiosurgery, and radiation can be ablative, and you can kill brain tumors with radiation. And with a strong enough radiation, you can kill brain cells. And so the sort of incisionless thalamotomy for the last 10 years before focused ultrasound came out was using Gamma Knife to deliver strong radiation rays to create that lesion. But the lesion doesn't happen right away. It takes months, so there's more variability. But they'd show in Southwest Airlines these pictures of that spiral, right, of making a spiral, and the essential tremor you see here, and how it's treated with an ablation, right? So that's the result of an ablation or DBS. But that's what we're trying to accomplish. This is one of the tests that we use, the CRST test, to show how an action tremor stops, whether it be with medication or intervention. So with focused ultrasound, I'm placing one of these frames on an awake patient, and you're basically going in and out of an MRI scanner. And in the MRI scanner, we're able to focus ultrasound energy in a way that can heat up the tissue, the targeted tissue, in a very specific way that we can track in real time. So I can see, while we're delivering this energy, the temperature of your brain tissue, and when it gets to the point where cells start to die, that's when you get the lesion. So that this is a thalamotomy, we're making a lesion, we're doing an ablation, but the safety of focused ultrasound is largely because we're making this lesion in real time compared to what we were doing before with radiation, which took months to develop. So a patient basically sits flat on the MR scanner and goes in and out as we test, check, double check, triple check that we're focusing the radiation, the ultrasound in the right location. This patient right here, their hand is up in the air doing this task, showing their action tremor. We're testing their language. And unlike DBS, which I described as an electrical therapy, this is the neurosurgeon is delivering the therapy here. The patient leaves not shaking, presumably, because of the ablation that's performed using the MRI to help guide the delivery of the ultrasound waves. So it's a thalamotomy. We talked about this already, but again, just keep in mind that this is an old strategy, right, doing ablations. And there's many ways to do this, including through a hole in the head, which is rarely done now. It's irreversible, it's not adjustable. And one thing we like to kind of, many people come in saying, this is minimally invasive, this is non-invasive. The neurosurgeons who do this are like, yeah, I get why you say that, but just remember, we're making a stroke, right? So I don't know how non-invasive you want to call this, since what I'm doing from out here is actually creating a stroke inside. So just, it's an important thing to be aware of. We've already reviewed alternatives. The indications, I'm not going to go through this, too many words for a slide, but just in December, they approved doing both sides, treating both hands with focused ultrasound. The caveat is the therapies have to be spaced out by 9 months. What that means is we want to make sure we accomplish our goals treating that first hand, and if that second hand really bothers you, you can go back and have it treated later. And I think that's because they've shown that with the precision of these lesions, they're not seeing the side effects that were more common back in the 80s and 90s when treating both sides of the brain in an ablative manner. It's approved for tremor-dominant Parkinson's. In Arizona, this would have to be done on a cash pay basis. Remember that once the FDA approves something, it takes some time before insurance, Medicare catches up, and Medicare is not covering this at this time, but it is in Arizona, but it is approved by the FDA. So all this stuff is changing. It requires a full head shave all the way down, not just like, where it's kind of like, a 5 o'clock shadow, like all the way down the bone, razor shave. There's zero sedation for this. So I'm numbing you up, you're feeling the bee sting as I numb up the areas where the pins go, and you're basically with that frame for about 3 hours. You're flat for probably less than 2 hours. But there's zero sedation. I don't have an anesthesiologist there. And if I give you any sedative, that could dampen your tremor. And about 2 hours, probably less, in the scanner. And while you're undergoing this therapy, this patient's head is basically wrapped in like a shower cap, and there's ice cold water kind of flushing the scalp, because the ultrasound, the big challenge with the ultrasound, it's amazing, the science, the engineering that went into this device, to focus all these ultrasound sources so they can combine at the area of interest. The big challenge is getting all that energy through that thick skull, right? And so what happens is actually the skull is absorbing energy during this therapy, and it can actually heat up. So the shower cap that this patient's wearing, full of cold water, is to keep things cool during the sonications, during the treatment. And as people undergo this, usually it's about 10, 12 seconds that they kind of feel that. And in the process, when we're actually doing the ablation, they feel like their feet are falling over their head. They feel like there's kind of like this vertigo feeling. But you have to tolerate that. You're going to be participating. And when it's finally time to do it, we do usually about 2 lesions, and that you can feel your skull heat up during that time. So that's kind of an overview of where we stand today. Regarding focused ultrasound versus DBS, so far nationally, it seems like the focused ultrasound patients seem to be older. I wouldn't say that the tremor control is better than DBS. Again, the ability to adjust a DBS system means that we can kind of fine tune things. We can go after go away from side effects, target benefit. So there's been no head-to-head comparison of focused ultrasound to DBS. So there's, from my experience, my understanding of lesions versus DBS, there's no reason to really think that tremor control would necessarily be better. But I do think that you're more likely to sign up for focused ultrasound than DBS, kind of in general, right? I think that, yes, ma'am. Yeah, no, it's a great question. I'm still actually wrestling with that. So focused ultrasound is as drive-through as neurosurgery gets. I mean, drive-through neurosurgery, right? Like you come in and like 4 hours later, you're leaving with your tremor gone and without a scar, right? I mean, that's a very compelling experience. And, if you don't want to be, seeing a doctor like Dr. Evidente every few months or every year for these check-ins, right? A lot of essential tremor is being managed by primary care doctors, for example. So you're not committing to this lifelong therapy, right? So there is an element of that. I've heard one of the highest volume neurosurgeons doing focused ultrasound said, if it was me, I'd have DBS. And I was kind of surprised because I just started doing this last fall, and I was like totally on board. I was like, this is so cool. And like patients are crying, my nurses are crying. Like these MRI nurses are usually they're used to just like doing diagnostic imaging. And to actually participate in therapy was a big deal for them. And so it's a happy day doing these focused ultrasound cases, and it's nice to see patients just leaving the same day with the tremor controlled. So your question about if this was me, what would I have done? I think that there's strengths to both of them. I think most young people seem to be getting deeper in stimulation still. I think unilateral one-side DBS is not done too often, but it's a good option if you just want to see what it's like to have that right hand treated. So I think the jury's out, and I think I'm a little bit too biased one way or the other to have like an unbiased recommendation for what I would do if it was me. One of my chairman was once asked a question about this kind of like, what would you have? And he's like, I would have the surgery and a mirror. He'd basically do, I think one of the things is like, who's doing the surgery on me, right? It's like, yeah, I'd want to do the operation on myself. Like, I don't know if I'd go to for DBS surgery. I'm like still like, knowing how the sausage is made, So so I think that this is a big deal, that the awareness people have in focused ultrasound is surprising, given even before it was FDA approved. So I think more people are coming out of the woodwork saying, I want my tremor treated because of the availability of focused ultrasound, versus somebody who's had essential tremor for like 30 years, right? They've been shaking, and I say, hey, when did you learn about DBS? And they're like, 3 months ago. Like, how have you lived 30 years with tremor and it bothering you, and you only learned about DBS like 3 months ago? But I mean, I think that's just kind of, again, that's the experience of essential tremor, right? You live with it. You don't see a movement disorder specialist. You just see a primary care doctor. You take your Primadol or propranolol. And it's like there's a psychological relationship with your tremor, with essential tremor, that I think is very different than the psychological relationship that Parkinson's patients have with their condition. And so there's more of that element of like, thanks, but no thanks, not for me, when it comes to surgery. So I think that's where it's kind of, there's a lot more gray, kind of going back to your question about like, what's the right therapy? Because I think each individual is different. And I've seen just firsthand the dramatic increased penetrance that focused ultrasound seems to have in terms of people being like, sign me up. Yes, sir.
If you have DBS and your tremors are not controlled, do you then have ultrasound, or you only have one?
Great question. If you already have DBS, can you still get focused ultrasound? The answer is no. I actually have a patient who's going to have his DBS system taken out and then do focused ultrasound, and the neurologist is already like, does he know it's probably not going to work as well? Like that's kind of what we're bracing for. We do informed consent. We make sure that they have what they need to make a decision. But there's a good chance that when we do focused ultrasound, that they're not going to get the result they're hoping for in signing up to having their entire DBS. Because it's one of the things with DBS, sometimes you have these patients, it's like, you're not happy with the tremor control, but you can't live without the therapy. Like you can't live with it, can't live without it. Some of these patients, you turn off the device, and this is, again, part of the psychological relationship some of these patients have with their essential tremor. They may be like, I still can't use this like fine Phillips screwdriver, but they forget what it's like without the device. So sometimes the neurologist has to turn off the device and say, this is what you are without this therapy, to remind them the benefits of the therapy. That's the long-winded answer to your question, but the short answer is the device would have to be taken out. On the flip side, if you get focused ultrasound, you can get DBS afterwards. Now, the thresholds for side effects may be less because you already have an ablation there, but you can get DBS after focused ultrasound. Another thing, because this is a lesion, a stroke, you can't unring that bell. It's irreversible. There's a philosophy, an approach with focused ultrasound that's better to undertreat than overtreat. So quality of life is the goal. If I give you imbalance from the focused ultrasound, that's going to impair your quality of life. So even though you're not shaking as much, if now you feel imbalanced, you need a walker or something, that means that our net effect on quality of life was like 0 or even potentially negative. And neurologists are very attuned to this equation, I think more so than neurosurgeons, that side effects will impact your quality of life. And so when making that lesion, that ablation, we can always go back and do another one. Easier said than done. I'm sure you're not like itching to put that stereotactic frame back on and be back in the MRI, but we can always go back and make a larger lesion, but we can't undo the lesion we make. And because the consequence could be side effects, that's again one of the principles when talking about ablations. So that's it. I think we're gonna have some discussion next. Thank you very much for your attention.